Good afternoon, everybody. Good afternoon, dear friends. And we are really happy with all my colleagues to welcome you for this webinar focusing on the complication of bifurcation left main PCI. It's really a great honor to have today three fantastic operators. Thierry Lefebvre, Jacek Legukto, and Goran Stankovic. The key learning objective today are to discuss together the potential complication when performing left main PCI. Second, to understand how to minimize the risk of these complications, and to learn, of course, the bailout technique for this kind of complication. Today, we have three consecutive cases present by Goran. Will present you a nice case of dissection. Thierry Lefebvre will present you a case of side branch occlusion during true left main PCI. And finally, Jacek Legukto will present you a very difficult problem of how to manage a stent protrusion in the aorta. So we can, you have the possibility to ask questions on the chat. Do not hesitate. I will receive this question and I will do my best to transfer this question to our three speakers. So I think we can move to the first case presentation with Goran Stankovic. Goran, are you ready?
Yes, I'm ready, and thank you very much for the opportunity. I selected iatrogenic left main coronary artery dissection. So here is the case: young female, 48 years old, with chest pain on exertion and rheumatoid arthritis. She had positive treadmill stress test. Echo showed normal LV function without segmental wall motion abnormalities. So she was scheduled for regular diagnostic coronary angiography. Here is a coronary angio, left coronary artery in two different projections, showing no coronary artery disease with significant stenosis. And then we have additional projection of the left plus projection of the right, showing that actually this was so-called normal coronary angio. And what happened next is sudden onset of chest pain 15 minutes after we finished coronary angiography. Here is the ECG, extensive changes on ECG. And of course, we urgently brought patient back to the cath lab. And this was a small injection into the left main, which showed clear coronary artery dissection line. We immediately stopped at this point. And question is what to do next. So there are multiple approaches, but I think the key one is to stay calm, to stop injecting contrast, and then reconsider options. Jean?
No, I think that if we can stay on this view and looking at the, if you can show us the left main dissection, okay. And all of you see the immediately feel the difficulty of this left main dissection, which is a large dissection involving all the lengths, at least all the lengths of the left main. So what to do? Goran say first, no more angio. Thierry, have you an idea?
Yeah, I think there is many options, but as it was said by Goran, no more angio, because each angiogram you do, you may increase the dissection. And so I think it's very important to stop injecting and to think about how to find the solution to rewire in the true lumen.
Jacek, you agree?
Absolutely agree. We should imagine that this is a life-threatening condition here. And with every contrast injection, we can just worsen the situation and not improve the situation. So the way to go is just to take first wire, try to introduce to LAD, then the second one to the circ, because both wires has to be protected if we have this dissection, which is so long in the left main. And of course, afterwards, we need to confirm if we are in a true lumen or not. In my practice, the best way to do that is just to use intravascular ultrasound.
Jacek, you say you replace the wire in the left main. Which kind of wire in this particular case you will use? A standard wire or a specific wire?
I would start with just the regular B&W or run-through wire. I would avoid to use hydrophilic wires as a first attempt. Of course, if they are not successful, then we can deliberate and choose another ones. But usually, I will go with a regular run-through intermediate or B&W universal.
Okay, so everybody agrees to the necessity and the usefulness to use intracoronary evaluation by Ivis. So, Goran, what did you do?
Yeah, thanks. As already discussed, wisdom comes from bad experiences. So we had some bad experiences in the past, and we learned that unless we use intravascular imaging, it's very difficult to make sure that you are inside the true lumen. Stenting the false lumen is potentially dangerous and can occlude major branch like LAD or the circ. So this is Ivis, so no contrast. Wiring, as both Thierry and Jacek said, wiring with run-through in this case, both vessels blindly, no contrast injection, and then Ivis on the LAD wire. And what you can see here, you see actually on the cartoon on the right-hand side, in red square, it's a large false lumen with very weak vessel wall structure and very small green true lumen. So our goal is to use Ivis catheter and then try to reposition wire inside the true lumen. Here is a schematic presentation. So currently what we have is Ivis catheter, which documents that both wires in the circ and the LAD are in the false lumen, and we try to get the third wire in the true lumen. After some attempts, we were able to see on Ivis, and you can see here on the again on the cartoon on the right-hand side, red area is again false lumen now with the Ivis catheter still in that lumen, but we see now wire which is convincingly placed inside green, inside the true lumen. And this is the most important step to make sure by imaging that we have wire inside the true lumen before proceeding. We reposition Ivis catheter on that wire which was in the true lumen, and now what we see again on the cartoon, we have a larger green true lumen with Ivis catheter inside the true lumen, and we see false red area outside. This is the moment that we seal the dissection stenting from the ostium of the left main towards the LAD, then pot, and then shallow, really small injection of contrast to check the flow. What we see here after NC balloon 4.5 is angiogram with slow flow, but we don't clearly see distal dissection. We wanted to make sure that we seal completely dissection distally. So we go inside with the Ivis catheter, and you see passage of the catheter throughout the stent going slowly distally. And you will see now between 4 and 6 p.m., actually 4 and 6 o'clock, you will see here residual dissection. So this was Ivis documented unsealed dissection distally. So we added second stent, and this is final angiographic evaluation showing good flow and no distal dissection. So this is ECG post-PCI immediately after sealing dissection. She is symptom-free, and she had uneventful hospital course. There was small rise in troponin T, 660, but no segmental wall motion abnormalities on echo. So if you have any comments how to make this even better and more user-friendly, let's discuss these other alternative options.
I have so excellent, and thank you. It's a great case, and really you demonstrate brilliantly how to fix this dissection. First, how to be sure that we are in the true lumen, and everybody saw this difficulty to be sure to be in the true lumen if you are not using Ivis evaluation. I have just before starting to the treatment, I have a question coming from the chat. Goran. By
Yes.
Dr. Ivan Sang. What's the cause of the dissection? Iatrogenic versus spontaneous?
Yes. But on the first angiograms, there was no dissection. Patient was free of symptoms. On 3 different angiograms of the left coronary artery, there was no dissection inside the left main. And 15 minutes later, she actually had a sudden onset of chest pain. And on small injection in the left coronary, it was really clear dissection plane inside the left main. So I believe it's a diagnostic catheter, which probably was not positioned properly and created this dissection. So I believe it's iatrogenic.
Okay. A second question. In the etiology of this dissection, question coming from Dr. Sayan Narayanan, whether osteum of the left main involved. In other words, when you did the coronary angiography, maybe there was a lesion at the osteum, and if this can be considered an acute coronary syndrome.
Actually, on the Ivis, ostium of the left main was spared. Actually, I believe that mechanistically, insertion may be uncontrolled entrance of the catheter created inside the body of the left main dissection, which then with flow expanded distally. So ostium was spared. On Ivis, there was no dissection at the ostium. But when we stent, we had to cover because there is always possibility to have a retrograde transmission of the dissection. And for that reason, we stented from the ostium of the left main.
I have another question concerning the ostium of the circumflex from Dr.
Yeah.
Adrian Sebastian, but we will come back in a few seconds. Just now a question. When we see this kind of large dissection, of course, we take certainly a 6 French at least guiding catheter in order to have the possibility to use a correct Ivis. And what will be the shape of the guiding catheter you will select? Standard shape, or in this particular case, a special shape?
Yeah, so Judkins has less traumatic tip, and I think choice should be towards less traumatic tip instead of extra backup catheter, especially when we document that there is a dissection plane already existing. With the engagement of the EBU, I think may worsen the situation.
We can ask questions to our colleague Thierry and Jacek. Of course, Goran demonstrate the really the usefulness of the Ivis. But if we have no Ivis in the cath lab, or if we have a really small experience with Ivis, what's the other option?
So, if we, of course, what we need to confirm in these cases is that we are in a true lumen with the wire, to avoid implantation of the stent in the false lumen, which would be probably fatal in such case, especially if you do that in the left main. So maybe the option that we can use is to use the microcatheter going very distal to the vessel and doing some small injections. We can clearly see if we just fulfill the false lumen or we see side branches and the distality of the vessel. It could be good confirmation of where we are. Of course, if the wire in the distal part of the vessel is negotiating side branches, especially many side branches, it's not usual in small vessels that this hematoma protrudes to small vessels. To the left main it can, to the circumflex, like it was shown by Goran, that both wires in LAD and SERG were in the false lumen. But if the wire is going in the distal part of the vessel to small septal branches or diagonal branches, it's also a good sign. However, it's not 100% sure that you are in a true lumen. So this is my advice.
Thank you, Jacek. And this was a question coming from Dr. Julio Andrea and Luis Delgado. Thierry, were the other comment on this?
No, I suspect that, I don't know, Goran, you didn't say if the patient, because of rheumatoid arthritis, were on corticosteroids. Maybe she was, and I think it's a risk factor for the spontaneous dissection, traumatic dissection during coronary angiogram. So she was on corticosteroids?
I don't have those exact data now, but you are right. And with the lupus or that kind of weakness of the vessel wall could be additional factor for enhancing the chance for having traumatic dissection.
It's very good remark that we usually see such complications in rather younger patients, and especially in those patients without severe atherosclerosis. And probably there are some connective tissue disorders which are asymptomatic and difficult to be diagnosed, which are behind this. But so this is very difficult to predict even such a situation.
Yeah, we saw on the Ivis that there is no actual atherosclerotic disease in the vessel wall. So you are right, maybe connective tissue disease could be predisposing factor also.
In this particular case, Goran, what kind of guide wire do you use? You are using the standard guide wire you use for all the PCI or the special one?
We start with standard, and I said in this case it's our workhorse wire, at least for my cath lab. It's either run through or BMW universal. My personal approach is run through, and then of course you have to increase the stiffness in case you are not able with Ivis guidance to re-enter in the true lumen. Slightly stiffer wire may help.
So I have a question again on Ivis by Dr. Chilkoller. How do you know that you are in the right lumen with Ivis?
Yeah, it's an excellent question. And if you see vessel wall structure on the images, you see actually adventitial tissue, which is very lousy, no clear vessel wall structures, while on the other lumen, which is like in aortic dissection, compressed and small, true lumen, you see more clear contour of the vessel wall. So that was,
there is another question from Dr. Farmanullah, but we will come back at the end. So stay here with us. We will come back to your question. I have just a question, Goran. Sometimes we use to be sure that we are in the right lumen, we place the wire in the septal branch of diagonal branch of the LAD. Can you really rely on that, or this could be discussable?
Yeah, I think to make sure imaging shows you clearly where is the position of the wire. But positioning wire in different small side branches could be one of indirect signs. What I would suggest in that case is to go again with the microcatheter, remove the wire and wait for the backflow. If there is a backflow, this is additional confirmation that you are probably in the true lumen. Don't rush with the injection of contrast. This is the key. You don't need to rush as long as patient is hemodynamically stable. Try to do every effort not to stent the false lumen.
Thank you, Goran. I have another question coming from Dr. Asif Nadim. The question is the following. If Ivis is not available in the cath lab, can we carefully slide a small vessel on the wire to see whether we are in the lumen? Can you recommend that or not?
I didn't got the question. What can we do?
You have the wire, and can we advance the balloon slowly, carefully, gently, in order to see if the wire, the balloon can cross, and signification of that we are in the right channel.
I wouldn't recommend that because for myself, having no resistance actually enhances the risk that you are in the false, not in the true lumen. So I believe microcatheter, or preferably have imaging possibility in the cath lab. Ivis preferentially, because you don't need to inject contrast.
So I have the last question coming from Dr. Farmanullah. He said that it's not flow limiting. The dissection is not flow limiting. Can we manage it conservatively as in a non-left main dissection? Is it different? Left main or non-distal left main?
80% of myocardial mass of the left ventricle is at risk with a clear and geographically clear dissection of the left main. So I believe this is not something to be managed conservatively. It has a high risk, and I really recommend to have Ivis, know what are the steps, follow the steps, and have colleague with experience with you in the cath lab, 2 seniors, to discuss every step before proceeding to the next. I believe dissection of the left main is life-threatening situation, and you should really do your best to evaluate, follow the rules, and seal it.
Thank you. It's very clear. So we learn. Thank you, Goran. Again, we learn a lot.
Thank you.
First, we have all the time to treat it. We cannot leave this kind of dissection in the left main. And second, you insist, Goran, on the usefulness of the Ivis assessment in order to be sure that we will place the wire in the right channel. I had a question. At the end, you place the stent in the left main and the second in LAD. There was a question from our friend concerning the ostial circumflex. Do we need to rewire the circumflex, do the kissing balloon, or the pot is enough for the left main?
Yeah, we did pot with 4.5. We went with Ivis. We saw opening of the image towards the circ, so we decided to stop at that point. We did not decide to do to expand PCI and Rewire and do kissing. In our view, with Ivis documentation of non-compromise, widely open ostium of the circ, we stopped at that point.
It's important to remark that even if you have still visible dissection in the circ, but the origin of the dissection is fixed with the stent in the left main, and you have good flow without symptoms of ischemia, usually this dissection heals in time spontaneously. So you don't need to implant another stent because it doesn't help the patient, especially for long-term follow-up.
Thank you, Jacek, and thank you, Goran. Goran, 2 words to summarize the case.
So 2 words. It happens. It's possible, even with the most careful maneuvers with the catheter, to dissect left main. Now I think we showed what are proposed steps, how to safely manage this complication, and to prevent, of course, you need to follow the rules of having coronary angiography with good position, coaxial position of the diagnostic catheter, good pressure curve, no damping before injecting. Probably we omitted some of these steps.
Thank you, Goran, for this great case. It was a great learning case. We learned a lot of tips and tricks. And now it's time to move to the second case, which will be presented by Thierry Lefebvre. And Thierry, are you ready for the case presentation?
Yes. Thank you, Jean. It's really a pleasure to be part of this great session about complication when dealing with the left main. So this is an 81-year-old woman who had angina since 2 months, and she was admitted for a coronary angiogram. As you can see, she had a lot of risk factors, high blood pressure, dyslipidemia, diabetes mellitus. EKG was normal. By echo, ejection fraction was 50%. Renal function was also normal, but she had a previous chest irradiation for breast cancer many years ago. Please notice that she is 52 kilograms and the size is very small. So she is 148 centimeters. So this is the view in left coronary system. You can see that it's clearly a Medina 111 bifurcation lesion with a lot of disease everywhere in this left main. And I want to remind you few rules which in my view are very important when dealing with left main PCI. The first is that it's very important to have an optimal view to see the separation of the two vessels, the LAD and the circ, and so to see the ostium of the left main. Usually it's a cranial view, it's not the spider view. Know before starting the procedure where are the difficulties and discuss with other colleagues or having a proctor if needed. It's also very important to wire both branches because you secure the procedure with 2 wires in both branches. And very important also to respect the fractal law in order to avoid carina shifting when you treat one of the 2 branches. A POT is a crucial step of every bifurcation. Now we know that whatever the technique, 1 stent, provisional, 2 stents, decay crush, we need POT several times during the procedure. And of course, it's very important also to learn how to solve difficult side branch access before stenting, but also after stenting. So maybe we can discuss about this case before starting.
I think yes. I have a question. You talk about Thierry, the importance of to have a right view of the left main bifurcation. So, what are the view that you use in daily practice?
Yeah, so we have 2 views to see the bifurcation. One is areocaudal, usually, to see the ostium of the left main and the bifurcation between LAD and circ. But to see nicely the separation between LAD and circ, the best view is a spider view. And it's very important because if you want to do a POT at the right place, you need to have this nice separation of the 2 branches. And we need also a third view, which is the ostium of the left main. And usually you can see clearly the ostium not in this spider view, but in a cranial view, some areocranial, so 1040, for example, or some eleocranial. So depends on the patient. So these 3 views are very important. Of course, the working view, in order to reduce the risk of X-ray exposure, etc., is the areocaudal view.
Okay, I think we can move on the case in order to see what you have done.
Yeah. Okay, so this is the areocaudal view. As you can see, a lot of disease everywhere in this left main, but also in the LAD and in the circ. So when we think about the case, we start to make some measurements. Of course, you can do intracoronary imaging also, but it's very important to have a good idea of this vessel before starting. So the guide is 6 French, so it's 2 millimeter in diameter, and you can see already that the LAD and the circ are very small. So LAD about 2 millimeter or less. But of course, there is a lot of disease. The circ is about 2.5. So if you make calculation to see what should be the correct size of this left main, it's about 3. So it's very small. So I think maximum could be 3.5. And Ivis is not very useful because there is a lot of concentratory enlargement of the elastic membrane, and then you don't know exactly what is the size. So in this case, the operators, after a lot of discussion, they decide to use a 3O stent in order to cover the left main and the proximal LED. You see that there is still some waste on the balloon. In this case, it was done after some predilatation. And this is a result after stenting left main to LED. We have occlusion of the circ. So of course, at that time, the patient had the ST segment elevation in the lateral territory. She had the chest pain. So what is the mechanism of this occlusion? I think we can, of course, discuss about that, but you know that there was a lot of atheromatous burden in this vessel. The stent was sized mainly according to proximal reference, so it increased the risk of carina shifting and occlusion of the circ. And so what to do at this level?
So Goran, you have this kind of occlusion of the origin of the left circumflex after stenting. What to do?
So the first step for me is to precisely position pot balloon, do pot, expand better proximal segment inside the left main. Hopefully, by doing pot, you actually open the struts in front of the ostium of the circ, and you may provide some flow, visualize the ostium of the circ, and if patient's clinical presentation is stable, this gives you some time after pot to try to rewire. If pot does not work, there is always, because of the discrepancy in diameter between left main and the ostium of the LAD and circ, there is always possibility to go with small balloon on the jailed wire behind the stent and re-establish flow, sometimes just by passing the balloon, even without inflation. Very important, if you aim to do jailed wire, balloon on a jail wire, it's very important to put first inside the stent on LAD wire, non-inflated balloon, because maneuvers on the jailed wire may damage the stent, and this deformation could prevent entrance inside the stent and compromise the whole procedure. So first step, balloon in the LAD, on the LAD wire inside the stent, and then small 1 or 1.1, 125 balloon behind the stent.
Okay, so you have the possibility of rewire directly. Second, rewire after doing the pot. And if it's not working, the technique of the gel wire and the gel balloon. So, Thierry, what did you do?
Okay, so Jean, we can, as you said, we can try to rewire, but I think it's not, in my opinion, as Goran said, it's not the first option because it will be very difficult because you have really pushed the carina and it's closed. Pot may solve the problem, and we'll see. And we have a wire in the circ, so we can use a wire to reopen the circ with a small balloon. So this is the case. We wired the circ because it was the most difficult one, the LAD. Then we stent from left main to LAD, but because the stent was too large, then we have pushed the carina and it's closed. The pot, by extending the proximal part of the bifurcation, will modify completely the stent, and you may reopen the circ by just doing a pot. Of course, it's very important to have the pot at the right place, and that's why the fact that you have two wires helps you to put the distal part of the balloon at the right place. And in this case, you have to go in the spider view. So, of course, if you are able to have flow, then you can continue the procedure and stent. If you are not able to restore the flow with a proximal optimization technique, you can use a balloon outside. It was described nicely by Goran. And by doing that, and you put the balloon up to the bifurcation, you restart the flow, and then you can rewire the side branch with the third wire. So in this case, what we have done is just to use proximal optimization technique. You see that we have the other wire in the circuit here. We have used a 3.5 non-compliant balloon to do the proximal optimization technique. And after that, you can see that now we have a flow in the circuit at the ostium, and it was possible to find the lumen to go in the circuit. Then after that, you can just open the lesion in the circuit, relocate the carina by opening the strut toward the circuit. And so this is kissing bone inflation. So now you have the carina in the center of the bifurcation, which is very important. And then you can position a stent as a T or tap configuration, deploy the stent, then do a kissing bone inflation, and finalize with a proximal optimization technique. And this is the final result in aerial view.
Excellent. So Thierry, we have a question coming from our colleague, Dr. Shariful Islam. The question is concerning the prevention, how to prevent this kind of side branch occlusion when we see this critical lesion, which is a left 111 bifurcation lesion, and he has for a double stent technique, starting by a double stent technique, here the usefulness of a decay crash. And it's true that if we use a decay crash, can you hear me? Because I have a problem with the line. No, the line. Okay. The question for Dr. Issam was concerning the use of two-stent technique immediately, particularly decay crash, in order to prevent this complication.
Of course. So I think in this particular case, we could have done a decay crash technique, starting with two wires, stenting the circuit first, or the LED first, because it's difficult to know which branch is at risk of occlusion. But we prefer, in this case, usually we prefer not to do decay crush. It's a very demanding technique. You need to do 3 kissing bone inflation, 3 pot. So it's very demanding. But of course, it's if you know how to do it well, and if you don't forget any step of the technique, I think it's a very good technique. In this particular case, I think the operators did not follow the rules, which are not oversizing the stent. So just respect the fractal law of the bifurcation. And of course, in this case, it's very difficult because there is a lot of atherosclerotic burden. And putting a 2.5 stent in the LED and the left main looks very special. But the patient also was very special. She was 142 centimeters in length. So I think the main mistake was using a stent which was too large for this patient and push the carina and close the vessel. But as it was suggested, I think decay crush technique can be also a good approach.
Yeah, this question, this comment concerning the two-stent technique and decay crush are also coming from Dr. Christian Popescu and Dr. Madhu Srihardran and Dr. Ham Value Islam. So we have a lot of questions concerning the use of two-stent technique in this particular difficult anatomy.
But I think in this particular case, we knew that it will be a two-stent technique. The question is which kind of two-stent technique you use. So following the rules of provisional and ending with T-tap or culotte, or inverted provisional, starting by stenting first the circ and then do at the end T-tap or culotte. And the other option is starting directly with decoupage technique.
Okay. So excellent. Any comment, Jacek or Goran?
Maybe if I can add something to this technique that was used by Thierry with the pot immediately after stent implantation, instead of going directly with the wire, because when you experience side branch occlusion, especially circumflex, immediately patient becomes symptomatic. Sometimes if it causes mitral regurgitation, also hemodynamically unstable. So we want to be very fast with the second wire to try to open the circ. And if the stent in proximal part, if it is appropriately implanted according to the distal main vessel LAD diameter, it is always undersized in the left main. So if you are going without pot with the wire, you can go with your wire behind the stent, between the stent and the vessel wall, and then gauge into the side branch, then dilate with the balloon. And especially if you are not with your balloon in the on the LAD, like Goran mentioned, you can be in a real trouble. So I believe that it is very important to stress that even if you experience the side branch occlusion, first step should be to do the pot, and afterwards to try to rewire to the side branch, which is occluded.
Goran, any comment?
It's a very important point, because you can go outside of the left main and then in the circ with not a lot of difficulties, and then you will crush the stent. So you transform the procedure in a decoupage technique, but you don't know that you are doing a decoupage.
Yeah.
Goran, any comment?
Yeah, again, just to clarify, even if you have difficulty after pot to go on a jailed wire, especially in large plaque burden, like in this specific case, there is always possibility, and we tested and it works, to use Corsair and create some space on the jailed wire behind the stent. As soon as you detach and you have some space, you can enter with the balloon. And this is something really armamentarium that we need to know. These are the options. And as in every complication case, you work slowly, you know step 1, 2, and 3, and you follow the algorithm in order not to omit some of important steps. You can make procedure much more complex if you skip a step. If you don't do pot, then you can create passing with the wire in and out and make procedure even more complex than it currently is.
Thank you, Goran. So thank you, Thierry, for this great case. I think that we learn a lot. It's not an exceptional complication. It's something which happened, in routine practice. So it was really important to see and to learn the different way to treat this kind of side branch occlusion. So I think it's time to move to the third case presentation by Jacek, which is a really interesting point and always difficult to manage. It's a problem, the issue of the stent protrusion in the aorta. Jacek.
Thank you, Jean. Thank you, Goran, for inviting me to this excellent webinar. It's a honor for me. And I would like to share my experience with something which I believe would be more and more often the problem in our CAD lab. So this is a 70-year-old male with a lot of risk factors, comorbidities, and because of that, this patient was disqualified from CABG and was treated with left-name PCI and two-stent strategy on May 2020, and this patient came back to our CAD lab on duty day because of the recurrence of res angina and some troponin elevation, and this patient was scheduled for control angiography. And this is what we found. This is right, which is nothing special, without progression of the disease, some lesions but not critical, and this is the left coronary artery. In multiple projections, the distal bifurcation looks fine. We see some stenosis in the ostium of the left main, which is, of course, very often difficult to be assessed with angiography only. However, definitely there is some narrowing there, also some ulceration. And we have really good opacification of contrast within the arteries. However, the operators, he had a problem to engage the catheter into the left main. He was afraid what happens here. How is it so difficult? He was not really sure. He expected maybe this stent is protruding to the aorta. Of course, we tried to save exposure of radiation exposure in our patients. So we use low fluoro mode. And when he switched to high fluoro, he immediately recognized what is the problem. And he found that this stent is protruding into the aorta, not up to 1-2 millimeters, which is very often, but it is like more than 5, maybe even 1 centimeter of the stent, which is protruding to the aorta. So we have a patient who is not a good candidate for surgery with acute coronary syndrome after previous left main PCI with some suspicion of the restenosis or some edge or some stent failure related to the problem which is in the ostium of the left main, and we have difficulty to engage the guiding into the stent. So at this point, maybe we can discuss, or of course, if you wish, I can continue what I did.
No, it's true that it's a really difficult case, really difficult. And the main question is how to engage the stent with the guiding catheter, how to be sure that we have the wire in the true lumen. So, any comment, Thierry?
No, I think it's as you said, a very difficult case. That's why it's very important when we position the stent during the first procedure to be sure that we are covering the left main at the right place, up to the ostium if needed, but not too much proximal. And sometimes people are using spider view, which I think is a very bad view for positioning the stent at the right place, because there is a lot of foreshortening, so you don't know where it is. So then when you have to deal with that, I think the best is to wire the left main. And usually you at the first attempt you can go in the left main, but you don't know where you are. Probably you cross outside of the stent and then inside. So you need imaging to check what you are doing.
Okay, Goran, what type of guiding catheter you will use in this particular situation? Standard Judkins, EBU or XB, or short left hand Platz?
Personally, I think the best way to control the level of trauma, if it's possible to control on the fluoro, is to use Judkins left. Okay. With both Amplatz and EBU, you have much more extensive trauma at the area of stent protrusion. And
excellent.
Imaging is the key. Imaging is the key.
So, the right view, Judkins catheter in order to try to minimize the trauma of the stent with the guiding, and imaging. So, Jacek, what did you do?
Let's go with the case. Before I start, maybe one short rebuttal with Thierry. I absolutely agree with his statement that the positioning of the stent in the ostium is crucial. However, of course, sometimes it happens that even if a good position during stent implantation, the stent jumps into the aorta. So it can happen. What is very important for all of us is to report this in case description. If you have it, just report this for the future procedures, for next operators to be aware about this problem before they damage the stent with the diagnostic catheters during the next procedure. So my approach was quite similar what you said. So the femoral arteries were not available, radial occluded, so I needed to use left radial, and I decided to use 4-0 Judkins left. And it's very important. Of course, there are no strict rules, but I did it different ways. So very gentle, try to engage with the guide catheter into the stent with the deep breath-in. I was quite sure here what you see, that I am just successful and much more easier than I expected. However, then I introduced the wire, and I started to use my intravascular ultrasound probe to confirm I am really going through the stand, and of course, immediately I felt resistance. So I didn't push because I was afraid that wire is going through the stand struts, not through the lumen of the stand. I stopped and I use what is my next approach. First is to use less traumatic guide, and second, I left this wire in the artery to have to much more easier control on the guiding, and try to use the second wire with the probe on this wire and to look for the lumen of the stand. And you see how easy it was to introduce the wire. So again, I was quite sure that maybe now I am successful, but again I am stuck with my probe, and again try not to use any force, and especially look on the images of the intravascular ultrasound when you do that. So you can see that I push the catheter and there is a resistance, and still I cannot see stand. So it's another probably confirmation that we are going with the wire not through the stand. So I removed this wire, and of course I repositioned a little bit the guide catheter, and I tried again with wiring, looking for the good lumen. Now, as you can see, I am coaxial with the catheter, and I entered. It looks like on angiography that I entered the stand. However, just a few millimeters inside the stand, I still see feel some resistance. So now let's again look at Ivis, what I see now, and this is very also important and very easy to recognize. You can see that again the wire went through the stand struts, and you can see the probe is in the aorta, and the stand is just lateral to the probe. So again, not a good way to go. So I was not successful for 15 or 20 minutes with this Judkins left 4.0, so I decided to change the catheter for a little bit more aggressive extra backup. Why? Because this procedure was done with 6 French extra backup 3.5, so I hoped maybe it would be now more easier to engage. Of course, as Goran mentioned, this catheter is more traumatic, especially if you have the stand which is protruding like 1 centimeter into the aorta. You have to be again very gentle and not very, very fast with this procedure. So again, it looked that I am in a good position. We see the contrast is going into the left main, so I wired again without any resistance. And then I tried with second wire to go with the probe. And as you can see, it was not so easy. Of course, there was not a good backup from this guide, which was not introduced into the lumen of the stand. And I was not sure, but I didn't want to go with the probe. I just changed the projection, which is also very important. It was in epicaudal or epicranial. It looked like the wire is going through the stand, and now we clearly see that both wires are going through the stand strut. So again, this was, I felt not comfortable with this extra backup catheter, which is of course my workhorse for regular left main procedures in 90% of cases. However, I then decided maybe with a smaller curve Judkins, so 3.5, it would be easier to get a control on the catheter and more safer to try to find the lumen. So this is now again from the left radial. I introduced the 3.5 Judkins. Try to engage into the left main. It looked quite okay, but it looked the same for an extra backup. So every time when I have the feeling that I am in good place, the next step, of course, is to wire and then to go with the probe. And here I didn't record it, but the first attempt was not successful, so I used the body wire to reposition the guiding, and this is another try with the second wire, trying to find a good lumen. And now, fortunately, I was successful. We are in a probe in the body of the left main, and I tried to pull it back. Of course, we need to do it gentle because it's very easy to damage the stand which is in the aorta with the guiding, especially if you have any resistance during the pullback of the guide. of the Ivis probe, and in the ostium you can see that probably the stent is fractured, and there is also a lot of soft tissue which could be the thrombus, which explains why this patient came back with res angina and troponin elevation. However, what is most important, I confirmed with Ivis that I am going with my wire from the guiding through the lumen of the stent and not through the stent struts. So now I'm ready to go for PCI if it is necessary. My decision was to perform direct stenting with a short 9 millimeter long 4/0 Zotarolimus eluting stent. Of course, positioning is much easier now than before because we see the stenosis and we are still, of course, inside the stent. So we would not protrude, but epicranial view, as Thierry mentioned, is absolutely crucial. Never do that in spider view or RAO, always LAO cranial, LAO epicranial. Post dilation with 4.5. And of course, it's time to check the result with intravascular ultrasound. Now this probe went without any resistance and we are pulling back again. Try to do it slowly. And here you see the double layer of stents, and as you can see now, the ostium is fully covered, stent is well opened. It is protruding, but it was not damaged because I was trying to be very careful with all the maneuvers from the guiding, but at the same time, afterwards, at the end, I dilated with the balloon all the stent which is protruding to the aorta. Just to summarize, this is the final injection of the contrast. However, of course, if you want to assess the result, Ivis is more appropriate. So this is just to check if there are no problems distally with, for instance, wire causing some dissections. And this is just to stimulate the final discussion, the case from the past, very similar. The patient came back after left main stenting for the PCI of LAD, and this was started with right radial approach, not successful. So we successfully wired the LAD and also introduced the probe into the LAD very easily. But during the pullback, we have recognized, as you can clearly see here, that this wire was introduced through the stent struts. And also in this particular case, probe went very easily through the stent struts. If you don't recognize this, and if you go with the balloon and stand and inflate the stent, the balloon in the LAD, and then during the removal of the balloon, you can even withdraw the stent from the left main, and such cases are in the literature, you can find them. And so knowing that I am not in a good position, I changed to femoral approach, changed into the Judkins guiding catheter, and using my 2 wires approach, I finally engaged the wire through the stent, and now you can see the pullback, and you can see also now stent distortion. So during all these maneuvers before diagnostic cuff and then first attempt, we damaged the stent in the aorta. Of course, it's not good to leave it like this. Maybe it could be the problem, but it's not if you are going with the wire through the stent, because then you just need to inflate the balloon appropriately sized, and this is the result afterwards. So it's very easy to treat such stent distortion, of course, if you recognize it on intravascular ultrasound and your wire is going in a good direction. Thank you very much for your attention.
Thank you very much, Jacek. It's a really great case, and thank you to show us all the different steps of the procedure. I have a comment coming from the chat from Dr. Jorge Eduardo Chavarriaga, and he said, which is true, because on the 3 consecutive cases, he said that much of the success of management to avoid complication would be the support with intracoronary imaging. And we saw in the 3 consecutive cases the major role of Ivis. Any comment, Goran or Thierry?
I absolutely agree with that comment. With time, we learn more and more how more predictable, safer, and optimized result can be achieved using image guidance. And we strongly recommend to have at least possibility in case of something going wrong. As you have saw in our cases, imaging really helped us understand the mechanism and then treat adequately.
Thierry?
I fully agree with Goran. I think we need intracorneal imaging at least when something is going wrong. I think it's very important. It's one of the recommendations that we made many years ago. Of course, you can use more intracorneal imaging, but at least if something is not clear, if something is going wrong, it's very important to do it.
So I would like to thank you, all of you. I think it's time to close.
Thank you, Jean.
Unfortunately, because we could discuss one more hour on this complication on left main. Thank you for showing us and to share with all the community present today these three consecutive cases. The first on the dissection of the left main, how to treat, how to deal it. The second of the thrombosis of the occlusion of the side branch after the stent implantation in the left main LAD. And finally, this really complex and difficult procedure, how to manage a stent protrusion and treating the ostial left main lesion. So I would like to thank you, all of you, for the quality of your case. We learn a lot, and this is really the main goal of this webinar, this PCI webinar. It's to learn tips and tricks, particularly today on this particular session on the complication during left main intervention. So thank you very much. Thank you for all the participants. We participate in the chat, and see you very soon in the next webinar, and of course in May in Paris for the next Euro PCR. Thank you.
Of course.
Thank you.
Thank you very much.